We're here and excited to have Kendrell Taylor with us, who is calling in from outside of DC and is a prevention manager at NASTAD. And for those who don't know, NASTAD is the National Alliance of State and Territorial Directors. I think I might be missing a word there, but Alliance of Directors. And we're so grateful to have you here, Kendrell. You have been so generous with us, with the services that you've offered, and the knowledge that y'all have been able to provide for our community. So please feel free to take the floor, and I'll go ahead and pull up your slides now. And if you want to go ahead and introduce yourself a little bit more for our audience.
Perfect. Thank you, Jose, for having us here today. We are, genuinely happy that you invited us. Again, my name is Kendrell Taylor. I'm a manager at NASTAD on the prevention team. And again, on behalf of NASTAD, thank you for inviting us today. If you, again, have not heard of NASTAD, we are a nonpartisan nonprofit association that represents public health officials who administer HIV and hepatitis programs in the United States. Next slide. Perfect. So just a quick rundown of what we will be discussing today. In this session, we will provide an overview of NASTAD survey findings of HIV self-testing amongst our members. And then we'll take a little time to discuss integration of HIV self-testing alongside other self-testing services. And then we will end the session today with just some best practices and considerations to help sustain HIV self-testing in and beyond COVID-19. Next slide. So jumping right in. Back in 2020, NASTAD, June of 2020, excuse me, NASTAD surveyed its members to learn a little bit more about how health departments are and were providing access to at-home HIV, hepatitis C, STI, and PrEP self-testing services. We sent the RFI out nationwide, and we received 38 responses from health departments. 21 of those jurisdictions currently offer HIV self-testing services. This represents about 55% of jurisdictions that responded to NASTAD's RFI. Most of these self-testing programs are a recent addition to expand the availability and of HIV testing services. Almost all of the jurisdictions, around 95%, currently offer self-testing mail rapid HIV testing kits directly to clients. And 5 of those health departments actually deliver HIV and STI kit self-testing kits that are client administered that they mail back to labs for processing. Almost 3/4 of health departments that responded to the RFI plan to expand self-testing services by the end of the year. And amongst all of the jurisdictions that responded to the survey, the following challenges were anticipated in establishing in-home HIV, STI, hepatitis C, and PrEP self-testing services. Excuse me. About 59% indicated challenges surrounding the commercial self-testing services available. 56% anticipated challenges with the integration of current care models and self-testing services. 43% anticipated shipping costs and logistics to be a barrier. 46%, a little bit more than 46%, anticipated issues surrounding reporting and secured communications with providers and clients. And lastly, 41% foresaw laboratory validation or self-collection methods being a challenge to implement. Next slide. So to assist with just of some visuals here, we published a map that shares information on state-specific self-testing services, as well as a map that shares state-specific teleprep programs. We'll continue to update these maps as more programs launch, and we'll be introducing a new map relatively soon that showcases state-specific PrEP assistance programs. Then if you go to the next slide, I'm sorry, too. This one is showing the the PrEP services. These current maps actually provide details on self-testing services and state-specific teleprep services that are available at no cost to the patient or client. Next slide. So in this section, we'll begin the conversation about integrating HIV self-testing amongst other self-testing services. And you can go to the next slide. So NASTAD is collaborating with Building Healthy Online Communities, otherwise known as BHOC, to support a national mailed HIV testing program called Take Me Home. This program currently distributes in-home HIV testing kits to persons at risk for HIV who face structural barriers to testing in clinical settings and who have not been tested recently. So how the program works essentially is that they use donated advertising on geosocial mobile applications to reach individuals at risk for HIV online. So they're looking at Grindr, they're looking at Tinder, they're looking at Scruff to pinpoint those ads. And if a user is eligible, the program mails out a rapid in-home HIV kit to the user's address that they provide. So I think, well, not I think, in the beginning, right now, we are in a pilot phase. BHOC, Building Healthy Online Communities, and NASTAD are in a pilot phase with the San Francisco Department of Health, Oregon Department of Health, and Marion County Department of Health in Indiana to expand self-testing services to include dried blood spot collection cards, or DBS cards, self-testing swab kits, and urine sample collections. This enables public health programs to offer in-home sample collection for STI screenings, hepatitis C serology, and any essential PrEP monitoring labs in addition to HIV testing. So how we structured this and what this program looks like is jurisdictions will now have the option to package tests to expand options for individuals. So essentially, the assays will be provided to the client and they will collect it in a micro container or the DBS dry blood spot card. And they will send that specimen to a contracted lab for processing. Test results will be available to the users and providers using a secure portal, and positive test results will be reported to health departments for partner services, linkage to care, and treatment. Next slide. So what we're doing now is we're in the middle of a process to provide efforts, benefits, showcase current models in place, and potential drawbacks of implementing a HIV self-testing into other services through a 4-part webinar series titled Self-Testing Strategies for HIV and PrEP Access, to provide an overview and a roadmap and resources to begin or enhance existing programs. So the series actually launched in October, and it focuses on 2 self-testing implementation routes. One is outsourcing self-testing to a commercial vendor, and 2, the second model is delivering services through a current public health infrastructure, which includes CBOs and state public health labs. Each webinar highlights models and innovations from health departments about their implementation of self-testing programs. And I am, if I'm able to, these these are all pre-recorded, and the ones that we have actually completed are available on our website, and I will drop this in the chat if it's available. And so, for instance, just to get back on track, we have currently hosted and covered the following webinar series in the topics in the series. So we kicked it off with just an overview of at-home testing through the BHOC partnership. So in this webinar, NASTAD, NCSD, and BHOC provided an overview of self-testing initiatives and focused on the Building Healthy Online Communities Take Me Home program, including details about the expansion that I just mentioned before. We also hosted a session where we talked about implementing self-testing and PrEP monitoring. So we invited Washington University in St. Louis, Emory University, and Cook County Health in Chicago, where they discussed and focused on approaches for clinical decisions regarding self-testing for PrEP and lessons learned while implementing self-testing in various populations. I'll stop here and highlight Cook County because they talked about a group whom we've always tried to find and keep up with ways to innovate and engage, which is lessons learned with self-testing from with youth. What they found was that youth actually preferred text messaging for recruitment and retention, and slides as a visual aid for consenting. So they saw a lot of and used a lot of social media advertisement and recruitment and for retention and beginning of PrEP care and HIV testing, self-testing. They also found that adults 25 and older were more likely to complete a dry blood spot self-collection for HIV testing and PrEP adherence via mail-in lab-based testing. So they saw that there was a higher rate of individuals who preferred the method of collecting at home for various reasons within their scope. And then they also found that bidirectional text messaging and reminders increased clinic appointment time and PrEP adherence. So they saw that engaging with them via text messages a couple of times a month or within the context leading up to their appointment date, they saw that individuals were able to engage a little bit more, felt comfortable asking questions and talking to those counselors through that sense. For there. And then the last session, we talked about innovative strategies for integrating self-testing for PrEP with providers and partners. So in this last webinar that we had in December, CDC, Howard Brown Health in Chicago, and the Iowa Department of Health focused on models currently in place with organizations by highlighting the overall model, outreach efforts, any order fulfillment, and resources available to promote within communities. Here again, I'll highlight Iowa's model, which it's getting a lot of momentum, where they explain their implementations and what they saw since COVID-19 presented. And so in the context of COVID-19, they found a need to continue to sustain the capacity for self-collection of these samples in a home base. And it not only addressed preferences, but it also supported public health mitigation strategies, including social distancing and also minimizing physical encounters in a healthcare facility for prevention and non-urgent care needs. So we've got a lot of feedback that this is helping to inform and build out current programs that are currently in place or thinking about being in place. The fourth webinar in the series, which is the final, will be and is forthcoming. And in just a second, we'll get into a little bit more of the logistics about what that looks like. But the focus will be on a self-testing toolkit that's currently in development, where we will highlight in that toolkit urging, and what we will do is urge jurisdictions to consider utilizing, supporting, and or promoting self-testing models for HIV and PrEP implementation to aid persons normally missed in traditional outreach. Next slide. So PrEP. PrEP is a...
Can you slow down, please?
Sure. So PrEP is a topic of discussion that we are, I feel, will always hear about, especially given how things are opening up. When evaluating PrEP in a self-testing modality, we actually, or in a self-testing modality and also in COVID-19, they jump out immediately. Teleprep programs jump out immediately as health departments public health providers seek to promote PrEP maintenance while adhering to current public health recommendations for social distancing. Excuse me. And as the reducing of numbers of new infections includes or is continued to be a priority, integrating HIV testing into PrEP services is still and is deemed an essential service by CDC, and guidance was provided surrounding in 2 programs experiencing disruption in PrEP clinical care since COVID-19 hit. Another strength of teleprep programs is their sustainability. Even before the pandemic, the context of our discussion on changes in coverage and potential decrease in 340B revenue, teleprep programs seem to be particularly resilient and had strong elements to make them financially suitable. So what this looks like is teleprep programs can operate at a fraction of the cost, requiring in-person clinical visits and adapting to existing infrastructure, as well as teleprep programs are positioned to remain sustainable, despite changes in the financial landscape for PrEP. This resiliency is tied directly to conversations around health equity. So by increasing access points for PrEP and offering PrEP with fewer barriers to access, these programs have the potential to address racial and geographic PrEP access inequities. Next slide. NASTAD is currently in the process and has launched a virtual learning collaborative to assist EHE jurisdictions ending the HIV epidemic jurisdictions in implementing a teleprep program. So the learning collaborative receives ongoing technical assistance from peers and subject matter experts to increase the uptake of teleprep programs. We got to this point by doing a series of explorational calls with health departments in EHE phase 1 jurisdictions and identified several models and challenges facing health departments and their funded providers to implement teleprep programs, including the following that are on the side, and I will touch on a couple of those. First being teleprep delivery models. And so this looks like providing detailed information about various teleprep models currently in place being implemented in public health settings using a comparative approach, discussions and concerns around promotion and education. So marketing, promotion, and educational program strategies that are particularly well suited for teleprep programs. Service quality improvement and program evaluation. What this looks like is teleprep specific tools and considerations to evaluate the program's operations, including federal and state reporting requirements. Teleprep regulations, again, just drilling down and seeing what state laws and regulations related to telemedicine, examining opportunities to establish cross-state programs, and also provider credentialing requirements and reimbursement policies. We'll also, and in the cohort, touch on minor and dependent consent and confidentiality regarding HIV and STI service delivery, and then drilling down into 340B program for PrEP. So specific considerations related to 340B program participation, and also a cost analysis and budget and scalability of those programs. So budgeting strategies, including payer mix considerations for insured patients and financing mechanisms that may be available to agencies for each agency related to PrEP cost in that category. Next slide. Perfect. So I'll spend a little time here to talk about which goes hand in hand to webinar 4 of the self-testing series, and talk about our self-testing kit that we are in the process of finalizing. So NASTAD and our consultant, Lisa Randall, and the Association of Public Health Laboratories have developed a toolkit that will be released in the very near future to help health departments and their community partners decide whether and how to incorporate self-testing for HIV, viral hepatitis, and STIs in their testing strategy. In this toolkit, there are very key issues and lessons learned that should be highlighted in regard to adopting self-testing as a strategy to promote and facilitate access to HIV, viral hepatitis, and STIs. And I'll go through each one of these here just to give a little synopsis of what's coming. We wanted to highlight and show that self-testing is just not one thing. There are numerous self-testing models which vary based on where and how testing resources are accessed, how and by whom samples are collected, are tested, how results are delivered, and whether and how healthcare providers and health departments may be involved in these various steps in the testing process. The paper also is highlighting that self-testing is a tool. Self-testing may be a tool to improve testing and advance program objectives like integrating testing or addressing stigma or uptake in PrEP, but it may not be the best or most appropriate strategy for individuals, agencies, or populations. As a testing strategy, it has to match the needs of various communities and communities of individuals who may be better served with other testing strategies. Next, it highlights the test performance is important. So there is variability among the different tests used in conjunction with self-testing. And as test performance varies depending on factors including the type of sample collection, and handling of that sample, it's important to carefully evaluate every test and the laboratories that are performing those tests. Data collection is also highlighted, and reporting of that may be challenging. So as self-testing strategies make data collection and program evaluation and public health surveillance challenging, it's important to make sure that development and or ensuring mechanisms for collection and reporting of that data include test results that are in that implementation plan. And lastly, we wanted to highlight that there are many different ways to implement a self-testing program, but that implementation plan, again, should match agency capacity. So the level of resources and capacity required to manage implementation of self-testing depends in part on how self-testing programs will be implemented. For example, if promotion, kit assembly, distribution, health communications with clients is centralized, that might require a little bit more staff time and effort compared to if those services are contracted out. On the other hand, if a jurisdiction or an organization provides more financial investment in the beginning, that may be required to contract with a fulfillment center or contracting with a commercial testing service. Next slide. So ending here, and then we can delve in a little bit more. We're going to talk about best practices, which kind of were highlighted in what the self-testing paper alludes to when it is released. Next slide. So we must know that expanding options to sustain HIV self-testing services in and beyond COVID-19 requires innovation, refinement, and adaptation of to communities and persons served. So there are many aspects that are included to sustain HIV self-testing. First and most importantly is community and stakeholder buy-in. Jurisdictions and organizations should regularly ensure collaboration and advisement with advisory groups, community liaisons, and also testing and linkage to care providers to ensure appropriate advertisements inclusive of the communities served is represented, strategies to increase testing, including appropriate tests selected, and communities served, and addressing barriers to obtaining testing, including convenience, decreasing stigma, and language. Next, you could separate all of these out, but I combined them together because they kind of go hand in hand. Quality testing, surveillance, and monitoring. So identifying the unique tests performed, confirming and evaluating the results, providing essential linkage to care services, are important client-tailored treatment and care services, including follow-up are essential to quality testing. This also includes communicating and collaborating with your public health laboratory, test kit manufacturers, and testing services and their affiliate laboratories to obtain data about consumers using test or testing services, including test results. Lastly, feasibility. Again, when we speak about feasibility, factors including state and local regulations impacting self-testing. So what does that look like for your particular state or jurisdiction? Are there any loops or hoops that you would have to go through for populations that you are looking to serve? Any negotiations and collaboration with kit manufacturers or testing services on cost to consumers, or purchasing kits or services on behalf of consumers. And lastly, coordinating across the jurisdiction or programs to weigh resources and expertise needed to implement or refine a self-testing program. So just to end off here, there is much promise to expand self-testing services. While there are a plethora of benefits, acknowledging that these challenges that present to ensure quality of that test, supporting those individuals in accessing needed prevention and treatment resources, and ensuring availability of data necessary for public health surveillance and disease control preventions is necessary. Organizations in collaboration with public health laboratories play a very important part to effectively use self-testing methods. So I will end there for presentation, and you can go to the next slide, and I am happy to talk or answer questions from that, or go a little bit deeper if we need to.
Thanks, Kendrell. I'm gonna see if we can go ahead and also copy your emails into the chat for everybody. But lots of gems from what you shared. I was taking lots of notes. My sticky notes are full. But I also wanna just take a moment to encourage our participants to ask any questions. If you'd like to come off mic, we can do that as well, and give you that option to ask a question directly to Kendrell. But while we're doing that, and while folks maybe percolate on some of the content you shared, was wondering if you could just share a little, while doing this survey, while looking over some of this data, was there anything that kind of surprised you about what you found out? Was there anything that really like stood out at first, as far as this information? I know sometimes you mentioned that, for example, in some places, they like texts more than maybe a telehealth visit, right? Like a video conference call, right? And so really having to have those kinds of tailored services, right, for the community that we're working with. But yeah, just wanted to see if anything surprised you, while pulling this together.
Yeah, so I'll say going through that self-testing series, and also just looking at the results, seeing how jurisdictions and how COVID-19 kind of, you know, knocked people off of their trajectory, with, everything closing down, and how they were able, and how, I guess I wouldn't necessarily say ill prepared, but how they were not able to grasp or have on hand like a roadmap to move that. That's actually stuck out a lot to a lot of myself, and my colleagues. But also on the flip side, as we've moved forward, their adaptation to be in the space, to mesh and gel with the population served. So, of course, uptake in their telehealth services, making sure that, like in the telehealth collaborative that I'm a part of as well, there is a jurisdiction, I think it's Texas, that is making sure, even though they have in person labs and appointments still available, they're pushing and adhering to people's needs. So if they are able to go to the clinic, they're able to do that, of course, with precaution, or if not, they're able to do labs via a lab and then follow up through that. So those were the couple that stood out to me and my colleagues.
Definitely, thank you for naming that, and also making sure that the examples you named were from the South. I love that. Yeah, Texas. There. Um, was gonna also go ahead and ask, because something that's come up while we've been delivering our own capacity building on self-testing has been how to offer these services to folks who don't live in traditional housing, right? So whether it's folks who are unhoused or folks who might be couch hopping, we know that that's, especially right now with thinking about the state of housing in the South and in this country, right? Something that's going to be coming up a lot. And I was wondering if there was anything you could share to that effect, around different strategies. I know some people have done drop-offs sites as well. And I didn't send you these questions in advance, so I apologize. But wanted to see if anything came up in that to that effect, because it's something that came to mind as I was listening.
Yeah. Right offhand, I know that we are in the process now of, still formulating and seeing what is available and what's happening. Offhand, I can't think of a particular jurisdiction that is doing, I take that back. Howard Brown Health in Chicago, so just a little bit north. They are within their context. They have a program, again, similar model, where they have services that are available at the brick and mortar site, but they are also having an uptick of their mailing out of self-collection samples or kits that's available. So a model like that. And then also, I believe it's in New York. So again, a little bit further north, not south. They have a similar model where they're completely virtual. So there are no in-person visits. Everything is either telephone or it is video conference, and they are following up via text message or via, I believe it's I think they're a little bit flexible. So text messaging and again, also video conference, where they're able to check in, follow up, help individuals if they have questions while they're performing the test at home. So they're on the phone with them and, walking them through on how to collect whatever sample is that they're collecting. So just those two models I can think of offhand. A resource is, I know the Denver PTC has those models in place. So I'm not sure if you're going to share that or not, but those are some models that you can see where they're able to pinpoint areas that do have individuals who have housing issues or are in rural areas to get them into care and stay into care.
Yeah, really appreciate the work that our SIBA cousins at the Denver PTC are doing. And I will be sure to include the link to the list of protocols in the follow-up materials for our participants. And I appreciate that you named Howard Brown Health, even though it's not in the South, if only because I know that they are also offering some harm reduction supplies in their test kits as well, which is something to be thinking about, right? I love that you said that, self-testing is not one thing, right? And, if that's one takeaway that I hope we end with this week, right? I hope that is it, right? That it can really be as abundant and dynamic as our community makes it out to be.
And like I said, when that self-testing toolkit it's on its way any day now. And I think that would have a lot of gems to showcase. And in there, they will have specific models that's being showcased and what that looks like, trials and tribulations within that. And then it'll also, provide a roadmap for jurisdictions if they're interested.
And we do got a couple questions that have come in. So we have one question via the Q&A feature from Brian Collins, who was one of our speakers earlier this week, who asked, were there many jurisdictions and the request for information, or that you've talked with subsequently, that are implementing more than one method of distributing self-test kits? So, for example, simultaneously distributing through CBOs as well as through a public health lab or a state health department.
I have to go back and check notes. I can't think on the top of my head that any are actually doing that. I know coming down the pipe for the BHOC project, California is kind of in that stage right now where they're doing duality with HIV, dry blood spot, and also PrEP, and also with the foreshore tests. That's the only model that I can think of offhand that's kind of close to that. But I can, if you want to shoot that to me, I can follow up with any information that I know.
Okay, yeah, and I would just add that, one of the things about the relationship side of this is that, at least at the Latino Commission on AIDS, at our wellness center, which does offer self-testing, they started their program through a pilot that the health department had done, right? Yeah. And so that was that first wave of kits. And then after that, people were able to kind of find other funding resources. So it's always operating in tandem, even if the relationships kind of rise and fall at different points of the program. We did get one question as well in the chat, which was if you had any suggestions on how to manage in-person testing and home test delivery at the same time. So I think maybe if you want just some of that question you were saying about places doing brick and mortar, also places doing the home testing. I think you were kind of saying that it really just depends on the capacity, right, of the agency, and sometimes you can contract it out. But if you wanted to maybe talk some more about that.
Sure. So as we probably are all well aware and know that, HIV workforce it needs a little work. We have people that are short-staffed. We have people that are, have different modalities. So first, I know, just making sure, or if see what staff capacity is to do that. I've seen a lot of jurisdictions and had a lot of jurisdictions drill in on the point of what is specific, or what could you get through red tape to help that particular client, in that case. So it's more so of a individualistic type of situation. So, if you are able in that jurisdiction, to say, hey, I sent a lab to this place. Can you go there? I'll call you, we can do it that way. Or if it's, self-collection test kits that you can have, or just making sure that you are able to meet that client where they're at, and then also making sure that a lot of jurisdictions, well, seeing if you are able to bend the rules a little bit. I'm a huge advocate of bending rules. I did that a lot when I was on ground, and honestly, that is how you make a difference in making sure that someone is, one, educated, and also making sure that they have access to services. So that's what I would suggest, or my feedback.
Mm, thank you. Yeah, and the person followed up saying most people want in-person testing, but we want to be able to offer home testing, right? So I think there's also this desire on both sides, right, of the spectrum. Like some places want to actually do this to help affect their capacity, and then there's also the clients that may or may not want it as well. So it's meeting each other halfway.
Yeah, and I'll follow up to that saying too. I know, and Texas is doing amazing works, particularly in Houston, Harris County, where again that model is they establish like an appointment based system with their counselors. So for those who were just very adamant about being in person, needing that support in person, those counselors were able to schedule, do follow ups. Some were able to, in some cases, take a self-testing kit to that particular person's house, put the kit on their doorstep, say, hey, I'm outside, and, call from the car. So it's just those stretches to meet people and accommodate as much as possible. That could help as well.